rating system. 5, 4, 3, 2, 1, 0, right? Normal, good, fair, poor, trace, 0. There's going to be one question on dermatones, right? So out of 20 questions, you know 2 questions already for the exam. So we're going to, if you get the ankle card, we're going to test the dorsiflexors and the plantar flexors. In real life, you would also test the inverters and everters, but because we're only going to do the knee extension, knee flexion, we're only going to do 2, okay? So the first thing, so I want you to take your shoe off of this, please. So why did I ask her to take her shoe off? If I'm testing the strength of her dorsiflexors.
Her shoe weighs something.
Exactly, it's a weight, right? So if I don't know how strong she is, I want to see if she can get a 3, fair, F, okay? Go through the full available range of motion against gravity. So I want to keep your knee still, and I want you to raise your foot toward the ceiling. So I look at that and say, that looks like pretty much the full range of motion for dorsiflexion. She gets a 3. That's very objective, right? From one person to the next, we'd all agree that's against gravity, pretty much the full available range. I'm now going to apply the brake test, B-R-E-A-K, not brake on a car. Stabilize her leg, and I'm going to put my hand on top of her foot. So come all the way up, and put my hand on the top of her foot. Let her feel my tension, force, and then I'm going to slowly push her foot down. How much force I use depends on the size of the person, their age, body build, etc. Right? So if it's a little old lady, I'm not going to use my maximum amount of force. If it's a big guy, I probably can't even generate enough force to pull it down. So she took maximum resistance. She gets a 5. Everybody good? If she takes some resistance but gives way, that's how we're going to pretend it's a 4. Okay? So she takes some, but then gives way. If she can raise her foot up but take no resistance, that's a 3. So if she can't raise it up against gravity, you have to slide up on the table so your whole leg is on the table, please. You lay on your side. And just bend your knee a little bit so your foot. So I put her in plantar flexion and now try to dorsiflex. So now she can do it with gravity eliminated. She gets a 2. Okay? If she can't do it in this position, I'm going to put her, maybe I'll shorten the muscle up a little bit and now try to do it. So now she can do it there. Because for every point in a range of motion, the muscle length and the tension the muscle develops changes. There's certain points where she's stronger or weaker. So if she still can't move it, but I feel the anterior compartment, so just tighten up these muscles here. I feel tension, but not enough to cause movement. That's 1, trace. No movement, no tension, 0. Everybody good? Okay, now you can slide off the edge again. So now we'll test the plantar flexors. So point your foot down. Can I call that a 3? How do you get a 3, people? Against gravity.
Flip over.
What's helping her plantar flex? Gravity. Hit the land in your stomach. You're going to get a workout today. Flex your knee to 90 degrees. Point your foot to the ceiling. That's a 3. Everybody agree? It's going against gravity. So now I apply the brake test. I'm going to try to push your foot back down. Don't let me. And I give her maximum resistance. She gets a 5. A little bit of resistance gives way. That's how we're going to be a 4. So I'm not going to do the pluses and minuses because that becomes much more subjective. So she can't do it at all. Got to lay on your side again. And now you start her off in dorsiflexion, and now see if you can plantar flex. That's a 2. Okay? No movement. I feel her gastroc. I feel tension, but no movement. That's a 1. Trace. So now we're going to do the hamstrings, since she's in that position. Just lay on your stomach. And flex your knee up to 90 degrees. That's a 3. Now, is that the full range of motion? No, but go further. What's helping her go down? Gravity. So you stop at 90. So come back up to 90. Now I'm going to try to pull your leg back down to the table. Don't let me. So I let her develop the tension and pull, and she gets a 5 or a 4. Lay on your side again. And now, put her in extension. Now see if you can flex your knee. That's a 2, right? Gravity eliminated. No movement, but I feel her hamstrings. I feel tension, but no movement. That's a 1. So now we can do quads. Let's come out the front. So extend your leg all the way. So full available range of motion against gravity. That's a 3. But when I apply the brake test, now I'm going to ask her to bend her knee to 30 degrees. By bending to 30 degrees, you eliminate the screw-on mechanism. Now, we haven't talked about that in this class, but as you extend the lower leg tibia, the tibia externally rotates on the femur and locks into terminal extension. So the knee is more stable. We'll talk about that when we get to the knee. At 30 degrees, the screw-on mechanism is eliminated. The bony stability is gone. I can isolate the quads more effectively. So now I'm going to try to push your leg back down toward the floor. Don't let me. And I push as hard as I can. She gets a 5. Some resistance gives way, 4. She can't take any resistance. She gets a 3. To get a 2, so you got to lay on your stomach one more time. Actually, on your side. Sorry, I said stomach. So now you start in flexion, and now see if you can extend. That's a 2. No movement, but I feel her quads. I feel tension. That's a 1. Everybody good? Okay, shoulder. This is not going to be against gravity. This was a study done at Duke University. And it was an EMG study where they stuck needle electrodes into all the muscles of the shoulder complex. And they asked to test the rotator cuff muscles. And they found where certain muscles worked at their maximum amount of effort. And all the other muscles that did the same motion worked at the least amount of effort. So this is on the lab exam, if you get the shoulder, these are the tests I want you to perform. So the first one, supraspinatus. Supraspinatus is an abductor. So in the old days, the people would have the person stand up, bring their arm out to 90 degrees in the frontal plane, and apply resistance. But what muscle were we mainly testing? Deltoid, and very little supraspinatus. But then, in the early 60s, a guy by the name of Frank Jobe, J-O-B-E, did the first EMG study. He was the team physician for the Dodgers and the Rams. And in that era was Sandy Koufax, Don Drysdale, Hall of Fame pitchers. And he found the best position for supraspinatus was not 90 degrees, but 90 degrees of abduction, 30 degrees of horizontal adduction, and then thumb down, what you call that the empty can position. Now, I realize you won't understand this, but in the 60s, if people chugged a beer to show that they drank it all, they would turn the can upside down. I know that's stupid. You guys would never think of doing that on St. Patrick's Day, right? Type of thing. Thumb down position. So 90, 30 degrees, thumb down. So for many years, that's what I taught. But the Duke people found an even better position. And the technology was in like 2014 when this was published, is higher tech. So now I teach it differently. It's 90 degrees of abduction, 45 degrees of horizontal flexion, thumb up, full can position. And you apply resistance. Okay? And you can take 5 or a little bit of resistance and 4. If you can get it there, but no resistance, that's a 3. Everybody good? To get 2, you have to lay on your back and put your arm at your side, and slide your arm out to the side. That's a 2. Okay? Gravities have been eliminated. You can't really get it a 1 because you can't palpate supraspinatus directly. It's covered by the trapezius and the deltoid. Everybody good? So the Duke people, they actually do it this way. 90 degrees of flexion, 45 degrees of horizontal abduction. Again, just many people call that horizontal extension. I like to say abduction because that's what the supraspinatus does. It's an abductor. So that's a little bit different. So the next one, top right, is for subscapularis. So you got to, actually you can stand up now. Subscapularis comes from the subscapular fossa, attaches on the lesser tuberosity of the humerus. So it comes from the back through the arm right to there. It's an internal rotator. So this is internal rotation, and that's a very powerful motion. Lots of muscles do that. But the Duke people wanted to try to test it where it was isolated. So if you can imagine my arm going through my body and going off the back, that's still subscapularis. But all the muscles here aren't working. So turn sideways maybe. Put hand and small your back. So this is not against gravity, people. So try to lift your arm off, small your back. So I'm going to call that a 3. I'm going to apply the brake test. I'm going to try to push your arm back in. Don't let me. Now, it's not very strong, that muscle, in this position. So I could just do it like that, and she'd lose every time. But I'm not going to be stupid, right? I'm going to let her feel the tension, and then I'm pushing what I think is a perfect amount, and she's pretty strong, all right? That's a 5. Now, how you would do it against gravity in a true manual muscle test, got to lay on your back again. I won't pick on you again this semester. So now, subscapularis is an internal rotator, right? Everybody agree? Internal rotation. Bring your arm up to 90 degrees of abduction. This is internal rotation. Everybody agree? So come up to 90. Why didn't I have her come all the way? Gravity. So I stop here. I'm going to try to push your arm backwards. Don't let me. And she gets a 5. Okay? Or a 4. Everybody good? But I want you to do the Gerber liftoff on the lab exam. So now you can stand up again. And to get a 2, you have the person lean over, have their arm externally rotated, and see if they can internally rotate. That's a 2. Okay, internal rotation. Okay, the last one, for infraspinatus and teres minor. This picture. For some reason, the Duke people left out teres minor. You should add teres minor to this handout. Infraspinatus and teres minor. So the position they found it was optimal. If this is 0 all the way around, flex 45 degrees. I'm going to try to push your arm into your body. Don't let me. So she's contracting these 2 external rotators, and that's a 5 or a 4. If it's against gravity, you do this is the opposite. She would come the opposite way. Anyone need to see that? Let's do it. Let's just so everybody's clear. On your back again. So this is external rotation, right? So abduct to 90. This is external rotation. Okay, come up to 90. I'm going to try to push your arm back down. Don't let me. She gets a 5. Okay? To get a 2, you lean over, start with the arm internally rotated, and see if you can externally rotate. Are we good? Okay, how much? So now we're going to do groin wraps too. I'll have more time on Thursday. You can pick somebody else to be the model.
Oh, I have to pick somebody?
Yeah. Well, pick the person who beat you. Okay. You're the model. Okay. So a groin wrap is for an injury to one of your hip, groin, adductor muscles. So all of these muscles attach to the innominate. Innominate is the correct, in Gray's Anatomy, you're not going to see the word hip bone. It's innominate, made up of the ilium, ischium in the back, pubis in the front. All 3 of those bones form the hip bone. The origin of all the adductors, adductor magnus, longus, brevis, pectineus, and gracilis, have their origin on the pubis and ischium, and they attach to the medial femur, except for gracilis, which attaches to the medial condyle of the tibia. Say grace before tea. Adductor magnus comes all the way down to the adductor tubercle. The brevis and pectineus are real short muscles. The most commonly strained muscle is adductor longus. So if you lift your leg out to the side, the tendon that pops out in your groin is adductor longus that inserts on the middle of the femur. So the purpose of the wrap is to provide compression and support, but also to prevent the stretching of the muscle. So all the adductors, if they come from here, attach here, they're adductors, bring the leg in, adduction. They're secondary hip flexors. The big ones are psoas major iliacus, and they're medial rotators. That's what the adductors do. Adduct, flex, medial rotate. So the opposite motions, people, of abduction, extension, and external rotation are going to stretch those muscles, okay? So we don't want that. So you can stand here and put your right foot up on the stool, and I'm going to use, actually turn around, face me, you stand on that side, please. So I'm going to use an elastic wrap. The key thing with elastic wraps is that they're elastic. They stretch. So I've got to take most of the stretch out of the wrap, but if I take all the stretch out, I risk doing what? Making it too tight, okay? So she's in a flex position, so it's going to be harder for her to go into extension, which is going to stretch. I want you to internally rotate your foot. That's going to make it harder to externally rotate. Now, it would be ideal to have her opposite leg kind of come behind her first leg, but then I couldn't put the wrap between her legs. So she's in the right position now. So I asked her where her pain is. And let's say she said middle of the thigh, so I'm thinking adductor longus. I'm going to anchor the wrap onto her leg. And I'm going to start by putting the wrap between her legs and then come around lateral and then come medial because I'm pulling her leg into adduction. If I went the other way first and come this way, I'd be pulling her into abduction and external rotation, which is what I don't want it to happen. So I take most of the stretch out, but not all of the stretch. Anchor it, and then I spiral up the leg till I come to the top of the groin area with the gluteal crease, and then I'm going to come across your body above the iliac crest. And then come down along the groin area and just repeat that. And I'm taking most of the stretch out, but not all of it. And you finish wherever you finish. Every time it's going to be different. So normally, I would ask I would get the roll of white tape, anchor it there. A lot of athletic trainers would put one strip of white tape all the way around. Now, when I tell her, you can step down. I'm going to tell her when she goes to practice, if the wrap becomes too tight, come right over to the sideline. I'll take it off and reapply it. Now, why would it? When she leaves, everything feels fine. But why at practice? Let's say she's a field hockey soccer player. Why might it become tight?
Blood flow to the muscles.
Exactly. Blood flow, muscles hypertrophy because you're running up and down the field. It begins to come too tight. She's saying the whole time, that damn Keith put this on way too tight. But if you tell him beforehand, if it gets tight, come back over, I'll reapply it. I know it's time to go already. There's never enough time in this class, but on Tuesday we'll make time to do this, okay? So